Hello? Hello? Hello?
Yes, ma'am, you are audible.
Yeah, okay.
Hi, Anjali.
Hi.
Good evening, early bird.
Yeah. कल का confusion नहीं होना चाहिए था, so I came early.
I know. Chalo, good. I think Nilima and all should join in the next 15 minutes. Computer chalu kar. Chalo na. Chalo. I just joined from the phone. I'll go on the.
Yeah.
So we were actually planning that e-bulletin release also, but that is not happening.
Huh.
So Nilima said that we might just touch a bit on substance abuse.
Okay.
So I think that will be after Reshma's talk, before Dr. Tushar Delia speaks on ketamine as antidepressant.
Okay. But do I have to be there complete? Because after my talk, I am actually leaving.
No, you can leave,
Okay,
not a problem. They will talk. They will talk.
Yeah.
No problem.
Hello, sir.
Hello, good evening.
Good evening, sir.
हे मनीषा यांनी तयार केलंय का काय ते सबस्टन्स अब्यूजचं?
मला माहिती नाही सर, ते निलिमाच करणार होती. काही बोलली का तुमच्याशी?
सकाळी झालं बोलणं.
ती मला म्हणाली की स्लाइड्स करायला वेळ मिळाला तर स्लाइड्स करीन, नाहीतर मी म्हणलं क्वेश्चन अँड आन्सर मध्ये घ्या, असंच डिस्कस करा.
चालेल. नाही ती म्हणेल त्याप्रमाणे मी सांगणार होते आता झालं की.
अच्छा. आता येईलच ती. रजू एक मिनिट. आय हॅव टू जस्ट जॉईन.
Dr. Anjali, on a lighter note,
Yeah.
What is the time that you give ECTs, in the evening or in the morning?
Morning, early morning. Because I feel really bad that my patients have to be hungry, have to be empty stomach for a long time.
Right.
Already त्यांना एवढी औषधांमुळे ना भूक लागते ना.
हे आता स्ट्रेस मॅनेजमेंटचं चाललंय ना.
मी मॉर्निंग मध्येच देते त्यांना.
Usually in 80s and 90s, the time used to be around 5:36.
Early morning?
नाही, evening.
नाही, मी 8-8:30 ला देते. आता 10 वर्ष एव्हरी सिंगल मॉर्निंग मी आणि रेश्मा भेटतोय. एव्हरी सिंगल मॉर्निंग.
आम्ही त्याचं काय आनंद नाडकर्णी बरोबर करायचो ना. तेव्हा एक कन्सल्टिंग झाल्यानंतर वगैरे साधारण त्यांचं ते व्हायचं.
म्हणजे लंच नंतर, लंच झाल्यावर
डिनर लंच नंतर त्यांना काही नाही द्यायचं, चहा वगैरे द्यायचं नाही. 6च्या सुमारास द्यायचे. आणि आमच्याबद्दल नेहमी बोललं जायचं, हे सगळे अनेस्थेटिस्ट सायकियाट्रिस्ट कडे संध्याकाळी जातात, त्याच्यामुळे त्यांना त्रास होत नाही.
हॅलो मॅम.
हॅलो. मॅम काय ग अचानक? हॅलो सर. सगळे एन्थुसियास्टिक लोक जॉईन झालेत. सर तुम्ही म्यूट आहात. बर्वे सर.
Varsha?
Yes, ma'am.
Yeah, Varsha, you can keep the chat, the meeting room open for everybody so that just join in. And once Dr. Nilima Kelkar joins it, now you can make her the co-host.
Okay, ma'am.
You will be waiting for the whole time or you'll be leaving? Varsha?
Yes, ma'am. I'm in.
You'll be around, na? Yeah.
Yes, ma'am.
What is the time that you give ECTs?
I can't hear who. Somebody spoke, sir. काय झालं?
No, Varsha is our
okay.
support. So I was just giving her some instructions. Varsha, so Nilima ma'am has joined. You can make her the co-host, Dr. Nilima.
Okay, ma'am.
You can make me also. I don't mind because I have nothing much to do actually. I can mute people if they are, We keep the chat room open for everybody to join in without us having to let them admit them.
मनीषाला काही नाही असं कधी होत नाही.
आहे ना,
Always has something to do.
मला हे ऐकायचं आहे ना आज शांतपणे. जाना एक बार बसने देनी है, ऐसा मुझे लगता है. ओके, जा पापा को पूछ के जाना. अच्छा जा.
And then video.
रेश्मा आणि निलिमा एकत्र आहेत का?
Yes, Meenakshi.
हाय.
Hello.
Hello.
Very nice that you are presenting today.
Thank you.
All the best.
Yeah, I need that.
Good that you are at Nilima's home.
Yeah, Mahesh is there to help us.
Yeah. Actually, by this time we should become expert, but still we are not.
After presenting one.
Yes, ma'am.
Varsha, you can keep the chat, the meeting room open for everybody. So
Okay.
that just join in.
Okay.
And once Dr. Nilima Kelkar joins in, now you can make her the co-host.
Okay, ma'am.
You will be waiting for the whole time, or you'll be.
हे सगळं रेकॉर्डेड आहे का?
हो, हे रेकॉर्डेड आहे बिकॉज हे सगळं मी जे बोलते परत येते.
So that's okay. We will start the recording once we start the meeting. Now we'll just start the sound. Thank you, Rajat.
See this? They can see this.
They can see you. You want to start?
हळूहळू फिजिकल मीट्स घ्यायच्या सुरुवात करायची आहे.
सर तुमचं नाव अजित अजित येते हा. महेश बर्वे इज अंडर द नेम.
काय माहित नाही मला, त्या मुलांनी कोणीतरी केलेलं दिसतंय ते.
माझं पण आद्या देशपांडे माझ्या मुलीच्या नावावर आहे.
हो, माझं पण रजत घोषच्या नावावर आहे. डोंट वरी.
मॅम तुम्ही रिनेम करू शकता म्हणजे.
हो, माहिती. वी कॅन.
मला नाही येत.
जाऊ दे.
राहू दे.
हॅलो डॉक्टर तुषार.
हॅलो एव्हरीबॉडी.
हॅलो सर.
हॅलो मोठे साहेब, नमस्कार.
काय मोठे
Your voice is little less, Dr. Tushar.
ओके नाव.
येस, वंडरफुल.
Now it is good.
हॅलो, आता येतो आवाज?
हो सर, येतोय लाऊड अँड क्लिअर.
अरे तू मुलुंडून बोललास तरी ऐकू येत आहे आता.
तुमच्याकडून नेटवर्कचा प्रॉब्लेम आहे.
हो. कर रहे हैं.
We are sharing in case if you want to check.
इफ यू वांट टू प्रैक्टिस, तुषार भाई, अगर आपको स्लाइड शेयरिंग प्रैक्टिस करना है तो आप कर सकते हैं.
हाँ, करता हूँ.
ये
इसका चालू है.
ये रेशमा का चालू है.
हाँ, मेरा चालू है.
तो रेशमा का होने के आफ्टरवर्ड आई विल डू इमीडिएट.
हाँ, चलेगा.
अरे करके दे, टाइम है तुषार.
हाँ, टाइम नहीं है.
Now you can scroll like this. You can see na Manisha slides.
Yes, loud, nicely clear, एकदम. No problem.
See me also.
Both of you I can see.
मेरा ऐसा लग रहा है शेयर लो. शेयर. ठीक है? या ऐसा इसको कर देते ना ऐसा. हाँ.
तो मी खरं तर तुमचं ऑफ करा मॅडम.
हाँ, you stop share करो. Okay. Yeah.
ओके.
अभी कहाँ से ऑन करना है? ये ना, ये बोला ना उसने, ये है ना प्रेजेंटेशन का.
रज्जू,
हाँ, निकाल के रखो.
इसमें से जाएगा तो I will have that old this thing, क्या कहते हैं उसको, that background.
Can you see it now? Slide मेरा.
Yes.
ओके, गुड. होता है ना चांगला. नो प्रॉब्लेम.
बंद करते हैं.
जक्कास. थैंक यू.
Ketamine therapy is actually picking up very fast. It's
Taking
helping a
up
lot
very
of patients.
इतना पेशेंट को इम्प्रूवमेंट हो रहा है
बहुत.
डे एंड आउट.
I have high profile cases on ketamine and doing very well.
Yeah, I have seen it. Many patients. Okay, ma'am. Stop share केलं.
अच्छा आहे. निलिमा, तू केल्या का स्लाइड्स त्या सबस्टन्स अब्यूज वर?
हाँ, मनीषा केल्या की 2-3 आता जस्ट फायनल बघते.
हाँ, चालेल.
हाँ, एक
इन्क्लूड करायचं की नाही करायचं?
करूया सर, आपल्याकडे आहे 5-10 मिनिटं.
आहे ना, ठीक आहे.
आता या कशा आपल्या लोकल मीट सारख्याच आहेत. सगळीकडे ऍडव्हर्टाईज करतो, पण जेवढे येतील तेवढे येतील असं. तू अपने फोन
मनीषा, आज दुसरी कुठली नाही आहे ना मीटिंग?
माहित नाही, बहुतेक नसावी. आपली तरी तशी काही नाहीये. मंगळवारांची असते एव्हरी थर्सडे, पण ती 8 वाजता.
मनीषा, साऊंड म्यूट आहेस तू.
मी रजशी बोलते.
अच्छा अच्छा.
Hi, Reshma, all the best.
Hello, thank you.
ये यहाँ से एको हो रहा है, इसका वॉल्यूम बंद कर.
रितिका इज शामिनी ना?
Yeah. Yes.
Yeah.
हाय शामिनी.
Hi, Minal. Hi, Manisha. Hi.
Hi, Shamini.
हाय.
नाम बदल रहा है तू? ये 3 डॉट्स पे आता है क्या? यहाँ पे जो 3 डॉट्स हैं.
हॅलो
एडिट प्रोफाइल.
सर,
बोला.
वेलकम सर.
हॅलो.
आमदार सर आहेत ना? हॅलो.
स्पीकर आलाय का?
जयपुरा रजू. कोण सर आले?
हॅलो सर.
हॅलो.
कामदार सर.
कामदार सर आले का?
हो दिसतात ना. नाव नसल्यामुळे कळत नाहीये.
हॅलो मिनल मॅडम.
श्वेता का?
निलिमा.
निलिमा हाय.
हाय.
काय झालं, तू दुसऱ्या रूम मध्ये चाललीस का?
हो, कारण इको येतोय तिकडे.
आधीच जा मग आणि
हो
बंद
हो
करून घे.
येस. कारण ना ते चॅट बॉक्स मधले क्वेश्चन घ्यायला वेन शी इज प्रेझेंटिंग आय विल नॉट बी एबल टू लुक ॲट द क्वेश्चन्स.
Yes, I understand.
ओके.
So it is better that you are in separate rooms.
या आय नो. हॅलो बर्वे सर.
हॅलो.
हॅलो डेडिया सर.
हॅलो.
ऑल सेट?
यस, ऑल सेट.
आप हुकुम करो ऐसा.
हुकुम करने वाले मैडम है.
नहीं रे बाबा, कोई नहीं है हुकुम करने वाला इधर. Manisha can do that, but
मनीषा इकडे तिकडे गेले म्हणून म्हणते का?
काय म्हणाली मीनल?
नाही तू चांगली मुलगी आहेस असं म्हणत होती. कधीतरी ती हे रेकॉर्ड बिकॉर्ड होत नाही ना हे अजून.
एक मिनिटाने स्टार्ट करूया मला वाटतं. है ना?
येस.
प्रीती शाह. हाय प्रीती, लॉंग टाइम.
श्वेताचं बघून मी परत ही बॅकग्राऊंड लावली.
व्हिडिओ ऑन केला सगळ्यांना आठवण
हॅलो डॉक्टर शहा.
हाय. थाना रॉक्स.
सर परमेश्वर ओळखलं ना हिला? प्रीती रैया आपल्या सायन्सची.
हो. घाटकोपरला.
घाटकोपरवाली. करेक्ट.
वेलकम डॉक्टर कृष्णा जोशी सर. वेलकम सर. तुम्ही म्यूट आहात.
Good evening to everybody, Butler.
Sir.
And all the best for this, all this as usual, another good seminar. God bless you.
Thank you, sir.
Sir is always present to bless us, but we are very touched. Every time sir is always there.
मी पण सायन्सची.
कृतिका. हाय कृतिका.
हाय.
फोटो दिखा ना तेरा.
अरे फोटो देखना है.
हाँ तो
सेम बैकग्राउंड. Nice topics.
Yeah.
Eagerly waiting.
Yeah.
Kritika, good evening.
Hello sir, good evening.
Tu came say, how are you?
I'm good sir, how are you? Nice to see you
All
sir.
well. Yes, thank you.
इला मॅडम तुम्ही पण हॅलो. इला.
Good evening to all.
Good evening.
Sarajji sahab, namaskar.
टीव्ही सिरियल कोण बघताय त्यांनी आपल्याला म्यूट करा स्वतःला. हा गेला. चलो. Mila, should we start?
Yes, I think we should start.
Yeah.
Start? Okay. Good evening all. I, Dr. Meenal Gadge, President of Thane ISA, along with our Secretary, Dr. Manisha Ghosh, and our team, welcome you for today's Journal Club meeting. Today's topic is very, very uncommon. Though it is uncommon, nowadays patients are coming with this problem, have become very, very common. I myself have changed the plan of anesthesia for a schizophrenic patient who was for a cataract surgery for a under local anesthesia to a general anesthesia, which was not planned at all. So these things are coming up a lot. So we need to have better knowledge about it so we can treat our patients much, much better. Secondly, as stress factor has increased everywhere, and as anesthesiologists also are going through a lot of stress of so many things handling at one time, single time. So we also need a stress management. And today we are so lucky to have senior psychiatrist Dr. Deshpande madam with us for this session. So definitely we will come to know few tricks and few things from her, which we can apply to reduce our stress. I welcome all our speakers and viewers, and I request our senior anesthetist and medical legal expert, Dr. Mahesh Barve sir, to conduct the further session. Mahesh Barve sir. Sir, आवाज muted.
Thank you, Dr. Meenal. Good evening, everybody. Welcome to the fresh edition of the Journal Club meet organized by our Thane branch of ISA. Now, with medical profession, the essential baggage is stress. More so if it is anesthesiology, as Dr. Meenal rightly mentioned just now. So we have invited Dr. Anjali Deshpande, a senior psychiatrist, to give us some tips on stress management. I take the opportunity to introduce and welcome Dr. Anjali Deshpande to this forum. Dr. Anjali is a senior psychiatrist who is practicing in Thane for more than 25 years. Initially, she was a lecturer at Miraj Medical College. Later, she was a consultant and the psychiatrist at Thane Mental Hospital. And presently, apart from practicing at Naupada, she is a director of a 40-bedded state-of-the-art psychiatry hospital, Insight Mind Care Center. I think this is a unique facility available to the residents of Thane, which is dedicated to psychiatry cases which require indoor care. You will be aware the plight of psychiatry cases requiring indoor care who are admitted in general hospitals. Things become extremely difficult, and it is a need of the day to have a separate establishment for such patients. Now, regarding her special interests, her interests are managing cases of depression, then stress in women and children, bipolar disorders, substance abuse cases, and anxiety disorders. Now I call upon Dr. Anjali Deshpande to take over and give us some tips. Dr. Anjali Deshpande, please.
I cannot see her. Manisha?
Yeah, let me call her up. No, she's there actually, Anjali Deshpande. Her video.
I saw her. She's there. She's there.
Samir Deshpande is.
Minal, she just called to say there's
Hello?
Yeah, she is
No,
there.
I couldn't hear anything what anybody spoke. Actually, there's something happened and it just went off.
Okay.
No
I've
worries,
just come back. I've
Anjali.
just come back from my phone now. It happened again. I don't know.
So you
I've
got
just
a
come
very
back.
glowing introduction from Dr. Barve, and now we are all looking forward to hear.
I haven't heard any of it, but it's okay. Okay.
You're on.
Yeah. You can all hear me, right?
Yeah.
Yes.
Yeah. Okay. So thank you to the entire faculty to have me here. Thank you, Reshma. Thank you, Nilima, to introduce me to this fantastic forum. And it is a pleasure to be here with all of you. When I told my colleagues I am talking on stress management to the entire group of anesthetists in Thane, the first thing they told me is, "Acha, to tuja purna session ata GA madhe honar ahe." So I was like, okay. Okay. So let's start about stress management. It always makes me wonder, कि आपण ह्या last decade मध्ये we've been talking too much about stress and stress management. As a child, I have never heard of stress. आणि our parents talking about stress management, time management. हे कधी कुठे नव्हताच. I have not even heard of these terms. Parents under stress or somebody under stress. आणि घरी खूप स्ट्रेस बद्दल बोलणं होतंय किंवा डिप्रेशन बद्दल बोलणं होतंय. This is all just begun in the last one decade. When we talk about stress, what first comes into our head is, oh my God, मला stress होतोय. असं झालेलं आहे माझ्या बरोबर, किंवा मला खूप काम असतो, मला खूप I am not able to balance work and pleasure. I am not able to cope up with everything at home. म्हणून मला स्ट्रेस येतोय, किंवा माझा we relate stress to external, we externalize stress basically. आपण स्ट्रेस आणि एक्सटर्नल सर्कमस्टन्सेसला खूप मिक्स करतो आणि मिंगल करतो, but it is not true. Stress is what is within us. It is not a circumstance that causes stress. Stress is what is inside us. We have the authority to control our stress. जे आपल्याला awareness नसतो ह्याच्याबद्दल. Let me give you an example. It's a lovely long weekend आणि decided to go on a nice family picnic. All set, bags ready, children excited, our wifey very happy, your husband eager to take this break, all ready to leave the house for this nice one picnic. Sitting in your car, leaving, it's drizzling slightly, nice greenery around with nice waterfalls on the side. You set with some soft music and driving on the expressway to go to a lovely destination like Lonavala. We are joking, laughing in the car, teasing, crazy stuff being done in the car, all very, very happy. And obviously expressway आहे, it's a holiday, 100 kilometers per hour तर सहजच होतो. तर आपण हे करताना, the vehicle in front of you suddenly stops and you have to give a sudden break. When you give a sudden break, what happens is the immediate, ouch, oof, oh my God, that happens. And then there is a rush of hormones in your body, and then there is a flight and fright reaction. That reaction gives you a fright of your life. That is an acute stress reaction that happens inside you. Your hands begin to shake. You get jitters. You start feeling an emptiness in your stomach. You get palpitations. You're frightened. What is this? This is a fight or flight reaction. Everybody, all of us know about this. This reaction is also called an alarm reaction. If this does not settle down immediately, and this goes on, what happens to you inside you? We've all of us have had that reaction sometime in our life, and we all know what that feels. A sudden jerk in your body that you call acute stress reaction. If you do not manage this stress and this remains with you all the time, this can turn into a chronic reaction. Chronic stress, as you all know, can cause harm to the body and to the other organs of the body. The autonomic nervous system is what gets activated, and during these periods of acute stress. All of us have constant fears in our body. When you talk about fears, you talk about fears of failure, fear of being alone, fear of rejection, a toxic boss that is all around us everywhere. We're always ready to just please the boss and do things to please him. We always have a busy to-do list. आपल्याला हे करायचंय, ते करायचंय, असं करायचंय. These fears are always with us all the time. So the body goes into a fight and flight all the time. So when we have this all the time fight and flight response, we go into a situation called chronic stress. The brain engine is like a car engine. We cannot keep running all the time. We have to know where to stop. we have forgotten to apply brakes. We are only accelerating and accelerating and accelerating. So you're bombarded with stress hormones. Stress hormones, which cortisol and adrenaline, are causing havoc inside the body. So more stress gets to more sickness. More sickness cause and effect, constantly going on and on and on. To calm the autonomic nervous system, there is a vagus in our body. I think anesthetists know that more than all of us, any of us. So when I'm talking about vagus, it is not about what happens in Vegas stays in Vegas. This vagus definitely acts on the body and tells the whole body that I am there to calm you down. I am here to give you a relaxing effect. But we fail to understand and use that. We do not use the vagus in our body. We have to start learning to be calm. We have to learn to apply brakes. Our accelerator always has a brake, and we don't remember that there is a brake. Stress is controlled from within, and we have to remember that. We cannot constantly say, "Ki mala hechamoye stress hoto hai and techamoye stress hoto hai." See, if stress is because of a cause, all of us are working, all of us are doing things, all of us are constantly running. So all of us have to have this stress. If it is the reason for stress, some people feel a particular circumstance is stressful, and the same circumstance may not be stressful to be. That means that particular circumstance is not the reason for your stress. It is you within you. It is your nature, your personality that is causing you to have the stress. You have to learn to calm down. Basically, we were all human beings. Apple human beings, we were just to be. आता है ना अपन human doings झालोय. Do this, do that, asa kara, tasa kara, do this because he is doing that, do this because he is doing that. Hey, do this because we have to do it. We have forgotten that we have to just be. Boredom is a part of life. We have to learn to accept boredom कधी कधी. काहीच नाही करायचं. हे कोणाला हल्ली पटतच नाही. काहीच नाही करायचं. असं कसं? Such a waste of time. But that is okay. You have to learn to chill. You have to learn to smile. You have to learn to just be. We are human beings. We are not human doings. Just be. Constantly काहीतरी करायलाच पाहिजे हे चुकीचं आहे. You can just sit outside the window and drink tea for an hour. Why do you have to sit and drink tea in half an hour and leave? Kashala, sit with your family. How many of us sit for dinners together? How many of us sit together and just be? ते आपण करतच नाही. Because we are just waiting to run. We are just waiting. Absolutely, Manisha, I agree with you. Doing nothing is also an art. You have to keep doing. Something is wrong. Aram haram hai. Gele te divas. Ata aram paije. You need to be just there. You just need to be chilling with children. When you are constantly running and doing things, our children are watching this. They know that stress is a part of life. They're watching it. They also learn it like that. Halli, how many children go to play? They're not playing because they don't see us chilling also. आपण constantly काम करतोय तर तेही बसून तिकडे मोबाईल बसतायत, मोबाईलवर बसलेले असतात. And आता तर लॉकडाऊन मुळे तर children are suffering immensely. Yeah, last 2 years, I think psychiatric practice has taken up booms because constantly patients are coming to us, and especially young children. Young children are suffering a lot because they have forgotten to play. They've forgotten to go out. They've forgotten to have friends. Their only friend is the laptop, the iPad, and the phone. आणि आता तर हे ऑफिशियल झालेलं आहे. They are supposed to get their laptop because त्यांचं सगळं ऑनलाईन झालं. I'm getting complaints of teachers and parents saying that the children are not even putting their videos on. Classes मध्ये the videos are off. And they are sitting on their iPad and playing games. आणि games म्हणजे कुठल्या प्रकारचे games? It's all aggressive. They're all shooting, fighting, jumping, running. There is no stop. There is no full stop. There are no parents to even see this because each parent is in their own rooms doing their online sessions. And the child is here doing his online session. They're exposed to things that they're not supposed to see at a particular age because everything is popping up on the mobile. So they are getting too fast. It's getting too fast. Human is evolved, but the evolution way brains are developed, but brains are developed to such an extent कि आपल्याला only running माहिती आहे, आपल्याला थांबायला येतच नाही. When we talk about stress also, आपलं to do list हे एवढं मोठं होत चाललंय ना आपलं bucket list की आपल्याला थांबताच येत नाही. Nobody's bucket list has just rest. Everybody's bucket list is मला इथे जायचंय, मला तिकडे जायचंय, मला हे करायचंय, मला ते करायचंय, मला एक मर्सिडीज पाहिजे, मला एक BMW पाहिजे, मला एक चांगला ड्रायर पाहिजे, मला एक वॉशिंग मशीन ऑटोमॅटिक पाहिजे, मला हे पाहिजे. There is no stop. Whose bucket list has just rest? There is no bucket list like that. Bucket list मध्ये फक्त to do list आहे. त्याच्यामध्ये again we carry a lot of baggages with us. आपले जे baggages असतात ना ते खूप heavy आहेत. The lighter your baggages, the happier you are in life. Lighter your baggages म्हणे, like I said, this is a baggage. The bucket list is a baggage. You remove that baggage. The baggage, it will come as it goes. You don't have to prepare it. It will just happen. It will just happen calmly. You don't have to aim for something constantly. There is a particular aim, you do it, you finish it. Wait, chill, and then go for the next. I think every bucket list should have a chill in between, an alternate. मी आता इथे गेले ना, आता मी आराम करणार. आता मी इथे गेले ना, आता मी आराम करणार. तो chill पाहिजे प्रत्येक bucket listच्या नंतर. Another thing is, we are forgetting to
Anjali? Dr. Anjali?
Yeah, I'm sorry.
Yeah.
Yeah. We also are forgetting two important things, the mantra of life, the mantra of happiness, that is forgive and forget. We hold on to our past very firmly. We hold on to our past very tight. Learn to let loose, learn to release. We do not know how to forgive and forget. तेव्हा ती मला असं बोलली होती, तेव्हा ती मला तशी बोलली होती. That I cannot forget. This is what I cannot, this is not done. No. Learn to forgive and forget. The more you hold on to things and hold on to garbage and hold on to dirty things in your head, it is going to cause you stress. Your cortisol levels are going to rise. You have to learn to forgive and forget. Just let go. Everybody cannot be like you. Everybody has their own personality, have their own way of life. You cannot expect them to be like you. You are yourself. You be the bigger one. You be the forgiving one. You be the one to forgive and forget. Believe me, you forgive and forget, the person who has hurt you or you think has hurt you will someday come back to you. You have to just learn to forgive and forget. There are also a lot of people who only are constantly judging. They're very judgmental. Hey, judgmental होणं पण चुकीचं आहे because you're constantly judging. You're in the middle of traffic. You're standing on the middle of the traffic. You're sitting on the red signal with thousands others of people, and you will sitting in the car, you will talk to your person next to you and say, hey, कुठून आले एवढे लोक? कशाला एवढं ट्रॅफिक मध्ये येतात लोक? कशाला फिरायला जातात? पण तुम्ही स्वतः तिकडे आहात हे तुम्ही विसरताय. पण तुम्ही आजूबाजूच्या लोकांना बोलणार. So we forget that when you're pointing one finger to you, you have 4 fingers pointing towards yourself. आपण खूप judgmental होतो. जजमेंटल होताना आपण हे विसरतो की आपणही तिकडेच आहोत. आपण त्या रॅट रेस मध्ये आहोत आणि आपल्याला जायचं म्हणून we're just running the rat race. We're just running and running and running. We do not know where we are going. We're just going because the others are running. We do not even know where we want to stop. We are just running to infinity. कुठेतरी आपल्याला तो रॅट रेस मध्ये असायला पाहिजे की नाही हेही आपल्याला माहित नाही. Do we even have to be there? अरे हे पळताय, चला चला पळा पळा पळा. When we don't even know where we are running. That is one of it. आपल्याला तो एक फिनिश लाईन ठरवायला पाहिजे. We have to know where our finish line is. Unless you know where your finish line is, you will never be stress-free in your life. Stress, when you are exhibiting stress at home, and when you are getting anxious, and when you are showing tantrums at home, remember, there is somebody in your house who is much younger to you, your child, who is watching you. Your reactions are going to be learned by your children. These are learned behaviors. These learned behaviors always are carried on to our children. You talk, you exhibit, your reactions are going to be taken by your children. If they don't take those, they will at least get a little aggressive and agitated. Unless you are calm, they are not going to be calm. These are all learned behaviors. Your phobias, your fears, your anxieties are going to be taken up by your children. So it is very important that you do not transfer your fears to your children. That is up to you completely. When we talk about venting, who do we vent to? There is nobody at home to vent to. आपल्याला बोलायचंय पण कोणाशी बोलायचं? There is nobody. प्रत्येक जण प्रत्येकाच्या रूम मध्ये बसून प्रत्येकाचा एपिसोड आणि सिरीज प्रत्येकाच्या मोबाईल आणि आयपॅडवर आपल्या रूम मध्ये बघतात. बोलायला घरी सगळे आहेत. लॉकडाऊन मध्ये सगळे होते. But how many of you are together? There was one mother sitting in her bedroom watching her series. There was somebody in the TV room. There was somebody in the children's room. Everybody was there, but nobody was with each other. Everybody's in their own rooms doing their own things. When this happens, again, your stress levels increase because you have nobody to talk to. There is nobody in the house to talk to. You don't know what the other person is doing. You have to learn to talk. You have to learn to vent. Where are those neighbors? I remember my neighbors coming to my house when I didn't like what my mom cooked. I went to my neighbor's house to eat food. Are mala माझे आईचं जेवण नाही आज आवडले. I'm coming to your house to eat. My neighbors' doors were always open. There are no neighbors now because we don't even know who the next door neighbor is. The ones who have good neighbors are the ones who are going to be stress-free. A little bit of gossiping in your life is very important. Gossiping is very important. You have to gossip. I'm not saying no. It's very healthy. But when it comes to harming another person, then that's wrong. Then that is bad. Are tiza dress kiti chhan hota na? That's okay. Perfectly fine to say it. It's not gossiping. You're appreciating. It's important to gossip. Are tini na aaj माझ्या बरोबर असं केला. That is not gossip. You're just telling her what you felt. Gossiping is healthy to a limit. त्याच्यापेक्षा जास्त anything is bad. Secondly, आपण जेव्हा बोलतो, where are these neighbors gone? It's because children, initially when we were kids, when my mom and dad had a fight, when I had a fight with my parents, I had people to go to. I had my aji azoba to go to. I had somebody to vent to. Halli, they're all nuclear families. Nobody for anybody to talk. Children कुठे जातील? मग ते जाऊन WhatsAppवर बसतात. मग ते त्यांच्या फ्रेंड्स बरोबर चॅट करतात. माझ्या आई वडील ना असे आहेत, माझ्या आई वडील ना तसे आहेत. They have no physical venting at all. You have to learn to be their best friend. तुम्ही हल्ली मला आहे ना आई वडील खूप येतात आणि बोलतात की माझा मुलगा खूप खोटं बोलायला लागलाय. Always remember, खोटं starts from you. If you accept what your child tells you, the child will never lie to you. जेव्हा चाइल्ड येऊन तुम्हाला सांगतो की मॉम आय हॅड अ क्रश ऑन दिस गर्ल. हो, हे काय वय आहे का तुझा? तुला काय क्रेझी, तू काय मॅड झालायस का? तू असं करतोयस, तसं करतोयस. He will never come and tell you. His hormones are jumping. He's at that age where he is going to have a crush. If he's going to come and tell you that he has a crush and you're going to react badly, he is never going to tell you. Remember, mind you, he is going to do what he wants. Whether it is a husband or a child or a wife, they are going to do what they want because they are individuals. But if you react adversely, they are never going to come back and tell you. They will do what they want behind your back. When तुम्हाला तो relationship जपायचा असेल, तर you have to accept it and tell it to them. If you don't like what he's saying, tell it to them, but at a point when it is a little more open and थोडंसं चांगलं चाललंय, तर हळूच त्याला सांगायचं की बाबा असं असं आहे, असं तुम्हाला बोललास, पण मला ते पटलं नाही रे. आपण काय करू शकतो का त्याच्याबद्दल? But at that point of time, if you react, he's never going to tell you anything again, and he's going to lie to you. Even about mobiles, about everything, a lie begins from you. Your reactions are very important for the other person to be true to you. If you react adversely, the person opposite you is going to lie to you. Thirdly, when you are talking about playing, it's very important the child goes out to play. See that children now आता lockdown पण निघालेला आहे. It's very important for you to socialize. It is very important for you to meet your friends. It is very important for you to go out, have your own space, and for children to go out. It is very important for children to go out and play physically. And हे आपल्याला सगळ्यांनाच माहिती आहे. These are all important for the endorphins to start jumping inside. हे causes of stress होते. Let me talk a little about how to improve your stress. What you should do little by little to help you to be stress-free. First of all, take a BMW. Now what a BMW is, not the car. It is, first thing, what you have to do about a BMW, you have to be extremely important. The first thing that I want to tell you, just a minute, is to breathe. Breathe. You have to breathe. Every morning, get up before you take that phone of yours and just start take your WhatsApp. You have to learn to breathe. Breathe. Concentrate on your breathing. Thank God that you have a lovely day. The first B in the BMW. Then the M in the BMW is your mind. Relax your mind. Breathe and feel the relaxation through your mind coming down. Feel good about it. And then the W, use good words in the morning. Good words like good morning, thank you. Say good things to yourself. That is a BMW. And that will help you to be stress-free as soon as you wake up in the morning. It's very important to have that BMW in the morning before you touch your phone and check your WhatsApp. That will help you to start your day in a better way. And then, secondly, you have to watch your C. C is S-E-E. Watch your C. When I say watch your C, S is your sleep. E is your exercise. And the other E is to watch what you're eating. These again are very important for stress. When I say sleep, everybody nowadays has a complaint of insomnia. A lot of people are constantly complaining of insomnia. And that is because of the major reason is the diet and the phone. The blue light on the phone that reflects on your eyes before you sleep causes insomnia. It interferes with the sleep hormones. Sleep hormones, the rods and cons in your brain also get confused whether it is day or night. It is very disturbing, the blue light. So you have to switch off your phones at least half an hour to 45 minutes before you want to go to sleep. If you plan to sleep at 11, 10 o'clock, please switch off your phones and keep it by your side. Actually, they also say that the subconscious mind knows that the phone is beside you. That also does not help you to sleep because you're constantly preoccupied with what's happening on your phone. Anybody's WhatsApp, then you get up, watch, see it again, keep it back. So actually, the best thing is switch off your phone and keep it away. But I don't think as doctors, all of us can do that. But at least keep it by the side and not see the phone 45 minutes before you want to sleep. There's something called a sleep hygiene. If you follow that sleep hygiene before your sleep, again, insomnia will absolutely go away. The first thing is to sleep regularly at a particular time. You know you have to sleep at 11. See that you go on your bed at 10:30. Do not have too much of caffeine after 5 in the evening. Your evening tea should be your last caffeine, or your tea or your coffee should be not after 6 o'clock. You should not be taking any of these. Even fluids, they say, do not take much of it after 7 because then you don't have to keep going to the toilet or to the loo after 7 in the evening. A fourth thing is take a little book, read a little bit before you go to sleep, not on the mobile, a physical book. So that calms your mind and you go off to sleep. You can listen to a light music, which you like, not hard music, something light that you can put you off to sleep. Fourth is to drink a hot glass of milk if you can with a little bit of ghee in it to give you good sleep. These are a few steps that I would recommend for a sleep hygiene. Secondly, eat the right kind of food. Outside food is contraindicated for insomnia. See that you eat good home food. Do not eat heavy food after 7 p.m. in the evening. Very important to have the right kind of food. Third, you have to have good exercise early in the morning or in the evening. Late exercise in the night, again, releases endorphins, again, stimulates your brain and you do not get good sleep. So it's very important to sleep, eat, and exercise the right way and the right things for having a stress-free life. These are very important. After that, you need to know that everybody in your house is watching you. You have to set an example in your house to lead a stress-free life. If you are going to smile, remember the smileys that are there in the phone, the smile, the LOL, the ROFL, learn to use them not just in your mobile, but in your daily lives. See that you smile at least once every hour, every day. See that you laugh out loudly at least twice to thrice in a day, every single day. And rolling off the floor loudly, you have to laugh really loud at least once a day. Learn to clap, learn to appreciate. When you go outside your house every day, how many of you smile at the watchman, smile at the liftman, smile at your staff in the hospital, wish them, speak to them? Remember, you appreciate them once and the smile that you get back really makes you stress-free. It really helps you. If you appreciate somebody, it causes a stress-free, it gives you lesser stress and makes you feel happier when the person in front of you smiles back at you. Learn to smile more, learn to clap more, learn to laugh out loud. Laughing is very important. Laughing therapies are very common these days, and that is because it really gives you a stress-free feeling. You really feel good. These are few tips that I can give you for stress management. Stress is a very huge topic, has a lot more that I can talk, but I think we can interact more with this. I end my topic here. Thank you.
Thank you, Dr. Anjali, for a crisp and compact talk. Importance of break in life, doing nothing, forgiving and forgetting. That means formatting your hard disk very often, sharing, venting, and advice is related to sleep, diet, very well taken. Thanks again for giving these simple tips to us. I think all of us will benefit a lot from this talk of yours.
Thank you, sir.
Welcome. Now we move on to the next topic. See, psychiatry is a unique branch of medicine. Here, there are hardly any investigations or tests which can help to reach a diagnosis. The clinician has to rely on the history of the patient or history given by the relatives. On some occasions, the history is not adequate, while in certain cases, you hardly get any history from the patients. Now, it is interesting to note that some agents, anesthetic agents, can be of help in this particular respect. Barbiturates like thiopentone are found to be useful in psychiatric practice. Today, I request Dr. Anjali and Dr. Reshma Jolly to discuss about the usefulness of pentothal in narcoanalysis or pentothal interview, as we call it, and share their experiences. I welcome Dr. Reshma Jolly, and I would take the opportunity to introduce her. She is a senior practicing anesthetist in Thane. She did her undergraduate from this Lady Harding and postgraduate in anesthesia from Maulana Azad College, Delhi. She is in anesthesia practice for last 25 years. And she is working with Dr. Anjali for more than 10 years. Now, over to you, Dr. Anjali and Reshma and your team to discuss this topic of pentothal interview or narcoanalysis.
So, Anjali, you can start.
Anjali needs to unmute herself.
Okay. Yeah. Yeah. Thank you, sir. You can hear me now?
Yes.
Yeah. Yeah. So I have been meeting Reshma, I think, for the last 10 years, and every single day we meet. Ek din chai saath mein nahi pi, so we think it's a little left out. What is happening today? Aaj kyun nahi mil rahe? So I think every single day we've been meeting for the last 10 years, either for ECTs or for pentothal, and recently now for ketamine. So we are in close association and been seeing so many patients, which is when she said we should talk about this. I agreed because really it has been of real help. Pentothal has been doing wonders in a few patients in psychiatry. Not everybody can we do pentothal on, obviously. There are a lot of, we do pentothal mainly on patients of somatization disorder who complain of constant pain and who cannot be diagnosed. There is no organic cause of the pain, and neither can I help it psychiatrically with antidepressants. That is when I need to know that where is this crux, where is the crux coming from, what is exactly happening to the patient, and why is this pain happening. They complain of multiple somatic complaints, or they have one particular pain in a particular muscle or one particular part of the body, which is when we begin to think, why is this pain not going? Secondly, we also have a few patients who have a particular personality, who something has happened in the past and he's not able to tell me, and there is some point of life where his life has changed and he has gotten into depression. So if there is a particular point in his life which has affected him so badly that he cannot talk it out, and it's not easy for him to talk it out, and he needs to come out of it, then we do a pentothal to take it out of his system. Thirdly, there are other things, depression unexplained, not helping with medicines, and we know that there is something that even the patient is not aware of. Sometimes he's not aware of what has been happening to him during his childhood and has to come out, then it comes out. So, and dissociation disorder also is another part where we can do pentothal in. So when we do pentothal, Reshma, I'll be explaining to you about the procedure. I'll just talk to you about one of the cases that we have had in the past. XYZ patient, 25-year-old boy, who had come to me with depression. He used to keep saying that he has this urge to keep cutting himself. He used to have this small blade in his pocket all the time, and he used to keep having these small cuts on his hand, and he used to say, something inside me keeps telling me that it's not worth living. But I want to live, but I don't know what to do. Unless I cut myself, I don't feel good. So we tried helping him with counseling. We obviously gave him a lot of antidepressants. I gave him mood stabilizers. He used to get all right, and he used to come back to this. After digging into his history, he used to tell me that we found out that he had no friends. He used to be a loner. He never had a crush on anybody. He was, being a 25-year-old boy, never had a crush on any girl, never had a girlfriend, never had a friend to speak to. Then we finally decided, no, I think we have to get into this in detail. There is something that is upsetting this boy, and this boy is not all right, and he needs to be coming out with his feelings. He wanted to say something, but he never had the courage to say it out to us. So then we decided on a pentothal, spoke to Reshma, fixed a date, called him, spoke to his parents, and told his parents that there is definitely something inside him that needs to come out, and he is not opening up. So then we decided to do a pentothal. We called him, started the pentothal. The first session did not give out much. There was a little bit of resistance inside him. He wanted to speak, but did not speak much. He spoke about his depression. He spoke about his himself being bullied. He said that also for the first time. In the 8th standard in his school, he had a lot of bully in his school, but he did not get into details in the first session. Then me and my psychologist sat together, and we decided, no, there is something else in this. We have to dig deeper. We had a second pentothal. The second pentothal, I told Reshma to go a little more deeper because I need him to speak a little more. She went a little more deeper, got him into a state where he was in between the conscious state and obviously unconscious state. And then we spoke, and he came out with saying that I used to have this group of boys who used to take me to the loo in his school. I wouldn't mention the school, obviously, in Thane. In the 8th standard, he was to be taken to the toilet, in the school toilet, and these boys used to go here. And because he was a very timid child, and he was he was an introvert and not talking much to anybody in school, he used to be bullied by these boys. This group of 4 boys would take him to the toilet, take off his clothes, and feel his chest, massage his chest, and he used to get bullied like that. And he never spoke about this to anybody. He used to keep quiet, come out, be very subdued. After that, he got into depression. He never told his parents, stop talking to anybody. Slowly, this boy developed homosexual tendencies. He developed homosexual tendencies because of all this bullying that happened. He used to enjoy being with boys. He used to enjoy friends as boys. He stopped looking at girls. And slowly, he came out with his sexual orientation, saying that, ma'am, I am a homosexual, but I am not able to say this out. I do not know how to tell my parents. I didn't even know how to tell you this. Which is when we got this point and we realized that he is now wanting to tell the world, but he doesn't know how to say it. This was a very major thing that came out on our pentothal. After that, we spoke to his parents. His parents obviously were they were devastated. They didn't know what to do. They didn't know where to go. We had a tough time talking to the parents. Now the parents and he have both accepted it, and he's having a good life. But that is when pentothal enters. When we have to get into the crux of the problem, we have to get into it deeply, we get into it. So this was one where we helped this patient get out of his problems. But remember one thing, people have this wrong notion about pentothal. They feel pentothal gets out everything that is inside you. No. If you do not want to say it, it will never come out. It just makes things easier for you to talk. If it is there inside you and you want to say it out, it will come out. But if you do not want to say it and it is just there inside you and you do not just want to say it out, it will never come out. We do not let that unconscious mind, we do not let that will not come out. He will hold it. He will hold it back very strongly. Then it's not that it is, it's not a confirmatory test. It will not come out 100%, but it will only it'll help him to come out with what he wants. That makes life easier for him. This was one patient. The second patient again talked about pain all the time. A lot of patients with sexual abuse complain of some kind of pain in their bodies and they do not come out with it. In pentothal, definitely that also comes out. Then we get to know where all this depression and where all this pain is coming in. So pentothal helps patients to come out with their injuries only if they want to talk about it. It will not come out if they do not want to talk about it. How to do pentothal, I'm sure Reshma will help you with that. Thank you. sir.
Yes, Reshma. I request Reshma to start the presentation.
Unmute yourself, Reshma.
Good evening, everybody. Thank you, Barve sir. Thank you, Anjali. So I'll start with the anesthesia part of the pentothal or the narco analysis. So by definition, the administration of barbiturates like pentothal, sodium, or certain other drugs to a patient in such a way that it slows down the brain activity and takes the patient into a trance-like state. So why is the pentothal preferred drug for this procedure? First, it is a fast-acting drug. It is freely available and it keeps the subject in the second stage of anesthesia, that is the hypnotic stage, for a long time so that the procedure can be completed very comfortably. Like other barbiturates, it binds to the GABA receptors and takes the subject to the twilight sleep, in which they automatically start delivering information which otherwise they were not doing in the OPD setup. Initially, some substitutes were used in place of pentothal, like scopolamine, sodium amytal, and midazolam, but pentothal gave the best results. Now, coming to the role of anesthesiologist in this procedure, for us, we have to take it as the same day-to-day procedure that we are doing. So we need to do the pre-anesthetics checkup, all the investigation, and we need to control comorbidity if the patient has. On day of the procedure, like other surgeries, patient comes fasting. The procedure is explained in detail to the patient as well as the family members. The consent of the patient is very important as well as that of the family member. The monitors with baseline readings are taken, IV line is taken, and glycopyrrolate is given. Sodium pentothal is prepared as a 2.5% solution and incremental doses of 25 milligram are administered, during which we ask routine questions about their family members, their friends, their hobbies. And during this, we find the patient goes into a talk mode. Over the time, the psychiatrist or the counselor take over and they go ahead with the questions for which this procedure is being conducted. In the Inside Mind Care Center, the procedure normally lasts from 30 to 45 minutes. Like Dr. Anjali said, some patients need more than one sitting if the procedure was not satisfactory initially. And speaking from my experience at IMCC, the success rate of this procedure is around 80%. So that is about the pentothal interview.
You have to present some slides, Reshma.
This is the first presentation about pentothal. So shall we wait or start the second topic?
No. Just if Dr. Anjali is there, I would like to ask her some things. Dr. Anjali, do you prime the patients prior to the pentothal interview, rather like giving them a, you talk to them and make them aware what exactly this particular this procedure is, so that they are in the better position. Yes. And secondly,
yes, sir, I definitely, yeah.
Yes.
Yes, sir. So your second question.
Regarding the missing links, sometimes what happens is, even if the person does not want to come out with the facts in totality, he may give you some hints, and whatever hints or whatever thing which he expresses during the interview can be used later by you to confront him and then solve that puzzle or put the jigsaw in place. Do you have any experience related to this?
Yes, sir. Yes, absolutely. Your first question, sir, definitely we tell the patient the entire thing. They're a little scared when I tell them that they're going to talk. You're going to tell me whatever is inside you. Then they get a little scared. Ma'am, the young generation talks of it as a truth serum. Madam, you're going to give me the truth serum?
Yes.
Am I going to say everything to
Yes,
you?
yes, yes,
I have had patients tell during the procedure telling me, ma'am, मैं ये सब सच क्यों बोल रहा हूँ? मैं ये सब सच क्यों बोल रहा हूँ? They realize that they're speaking the truth.
Correct, correct.
And then I calm them down saying, it's okay. There's nobody else in this room and it's going to stay in this room. Nobody is going to know anything about it. Then they start talking. And secondly, as you said, sir, I definitely get hints. I keep in mind all the hints that they have been talking. I get these hints and I then go on to a third pentothal to dig deeper into those hints.
Yes.
Because I do not want to talk about these hints when they are in full conscious state, because then they start feeling guilty. Oh, did I say this? So I take it out in the next session, and then they start talking it out.
It is helpful. One more thing related to psychosomatic illnesses. Like we had a couple of patients who had stress-related pain in the neck, or they were not able to maintain the position of the neck whenever they are stressed out. So following pentothal interview, it used to be effective. And the psychiatrist concerned, he used to give suggestions later on towards the end. Say if the particular procedure is for removing that particular habit or overcoming the stress or that particular trigger, do you follow the same practice?
Yes, sir, I do. I give suggestions and I also help them to come over that.
Correct. Great.
Yes, sir. Yes, sir.
I would share a couple of cases which we did long ago. Like there were 2 school children who were not attending school, and probably they got into this drug abuse thing. It was way back in the 90s. There we didn't have much facilities. Like they were studying in one school in Thane. The timing of that school was 9:30 to 4:30. What these people, one boy was coming from Dombivli, other from Bhiwandi. They used to start from their house, come to the school, or come to this that particular place and then vanish and go back home at that particular time. Bhiwandi boy used to come by bus, go back by bus. His routine after pentothal interview was found to be going to Thane station, going to VT, coming back. And there were 2 places in Thane which supplied these drugs or some hashish or charas or something of that sort. One near the station and one near Kivilla opposite Holy Cross High School. Following this pentothal interview, they were just not ready to reveal the history as to where they were going. And Pinto interview was successful in pinning these places. And later on, action could be taken by the authorities against those particular establishments. And on the lighter side, we were matchmakers in one case. We were one person for attention seeking. He had injected mercury in his own body. He landed up with a surgeon to start with. After removing mercury from 2 or 3 places from his body, ultimately he was referred to the psychiatrist, where he ultimately confessed that he wanted some attention, and finally he succeeded. It was that entire exercise was useful for him.
Yeah. Sir, normally his substance abuse patients are a little difficult. Not everybody comes out with it. I have had a case where one of them have confessed, and I have had a case, I have done 2 sessions with him, but he just did not open his mouth. He just did not. And I was so sure that he was taking something, but he just did not commit. He did not. So there are a few who are very strong and don't let out.
And the last thing which we had discussed the other day, like on my insistence, the psychiatrist was not ready to do that actually, but since the patient happened to be our friend, he had that habit of, one had a habit of smoking and other was with alcohol. That problem of alcohol was there in these 2 cases. Patients were known to us. Just to give it a try, we tried it on these people. But de-addiction for de-addiction purposes, it was hopeless. We didn't have good results at all. In fact, the person who was consuming alcohol started liking it. So following that, we just, that was not the right thing to do.
Right, sir. Right.
Yes,
Yeah. Thank you, sir.
Minal, shall we take questions right now or later on?
Whatever you feel, sir. We have enough time, I think.
We'll take the questions now because Anjali might have to leave. So whatever questions are directed at her, we'll take them now.
Hey, consent, somebody has asked related to consent. Consent is the usual consent which is taken.
Yeah, we have a normal consent form.
Yes.
Yeah. If he's above 18, he can consent. If it is a child, then we have to take the consent from the parents.
Correct.
Yeah.
There was one question related consent if the patient is schizophrenic. Then whose consent would you take, the patient's or the...
No, we wouldn't do a pentothal on a schizophrenic.
Okay. Yeah, there was one question like that.
Sir, we can move
further.
We can move further.
Okay.
Yes, sir.
Thank you, Dr. Anjali.
Thank you,
again.
sir. Thank you, sir. Thank you so much, sir.
Okay. We'll move to our next topic. In our clinical practice, it is common for our patients to have comorbidities for which they are taking medicines. They take antidiabetics, they take antihypertensives, they take blood thinners and different agents. It is not uncommon nowadays to have some of our cases taking psychiatric medicines. In a minority of the cases, the patients may be victims of substance abuse too. Now I request Dr. Reshma to discuss various commonly used drugs in psychiatry, their interactions with anesthetic agents, and the care and caution required in such cases. Over to Dr. Reshma.
Thank you, sir. Can you see my slides? Because
Yes,
I
sir.
think the first talk, you could not see the slides. So we come to the classification of antipsychotic drugs and their interaction with our anesthetic drugs. The majority of the drugs can be classified according to their clinical applications. So we have the antidepressants, antipsychotics, mood stabilizers, anxiolytics, and hypnotics. Another classification can be according to the potency of the drug, the high potency first generation or the typical drugs, and the second generation atypical are the low potency drugs. The mechanism of action of most of these drugs is by altering the concentration of neurotransmitters, namely dopamine, serotonin, norepinephrine, and acetylcholine. But there are some exceptions like lithium, which acts directly by inhibiting the enzyme inositol 1-phosphatase, and there are other like ketamine, which targets glutamate. So what are the challenges for us anesthesiologists when a patient is on antipsychotic drugs? The physical condition of the patient is very different from that of a normal patient. Patient might either be too sedated or might be aggressive and might not be so cooperative like we find in other patients. The biological response that the patient shows to stress is also impaired. These patients normally are on long-term antipsychotic drugs, so there is some or other systemic effects which these drugs have that might interfere with our drugs. The post-operative management of a psychiatric patient differs from that of a normal patient. After the surgery, we might need to keep the patient sedated for a long time. So that is one extra few post-operative care we need to take. Now let us come to the different classes and the interaction that they have with our drugs. The first group of drug is the antidepressants. The patients who are on these drugs, by the look, they look sad, pessimistic, and very withdrawn. The majority of drugs in this group are tricyclic antidepressant called the TCA, the selective serotonin reuptake inhibitors called SSRIs, and monoamine oxidase inhibitors or the Mao inhibitors. One thing that we need to remember is all these drugs need to be continued till the perioperative period, because abrupt cessation of the drug can lead to discontinuation syndrome, and that we can see in the patient as anxiety, aggressive behavior, irrational behavior. So if the patient is on TCA, then there is inhibition of the reuptake of epinephrine and histamine, which can lead to postural hypotension, urinary retention, dry mouth, and blurred vision. Chronic use of this tricyclic antidepressants can deplete our catecholamine levels in the body. So there is increased response to drugs like atropine, which cross the blood-brain barrier. Patient shows high blood pressure, tachycardia, and confusion. In these cases, we should not be using sympathomimetics like ketamine, pentazocine, etc. The commonly used tricyclic drugs are imipramine, that is like dapsonil, amitriptyline, doxepin. So the next group is the selective serotonin reuptake inhibitor group. These drugs are used in when there is mild to moderate cases of depression. And like the name suggests, they block the reuptake of serotonin at the presynaptic membrane. These drugs have less adrenergic or cholinergic side effects. Examples of this group are fluoxetine, which is called Prozac, and there is sertraline, which is Serta. Fluoxetine can depress the hepatic cytochrome 450 enzyme. So the drugs which undergo hepatic metabolism, their level in the blood increases. Commonly used drugs like that are theophylline, warfarin, and our benzodiazepine. Similarly, we need to take precautions when you're using drugs like tramadol and pentazocine with these drugs. Some of the SSRIs also have antiplatelet activity. So during surgery, there are more chances of bleeding or oozing. There is a syndrome called serotonin syndrome, which is because when the serotonin levels rise to very high in the spinal cord and brainstem, the patient shows agitation, confusion, and increased motor activity. The next group is the Mao inhibitors or monoamine oxidase inhibitors. Because of the high side effects, these drugs are not much used, but if they are used, we need to be extra careful with these drugs. These drugs also inhibit the metabolic breakdown of norepinephrine and serotonin, and they rise the level of norepinephrine and serotonin. Mao inhibitors can have two types of reaction. The type 1 is the excitatory reaction, and the second one is the depressive reaction. Indirectly acting sympathomimetics like ephedrine can lead to hypertensive crisis. So these drugs are contraindicated. Also, local anesthetic which have adrenaline, they also should not be used in patients who are on Mao inhibitors. Example of Mao inhibitors which is sometimes used is phenelzine or Nardil. Phenelzine has the property of inhibiting cholinesterase enzyme, so they can increase the action of succinylcholine. We need to be careful during that. There is another group of disorders called the bipolar disorder. The patient has swings of depression and excitement, and drugs of mood stabilizer group are given to these patients. Commonly used mood stabilizers are lithium, escalate, and valproate. So one caution about lithium, among all the drugs which are used in the psychiatry, lithium is the one we need to be very careful about. This is the only drug which need to be stopped before the surgery, and at least 72 hours before the day of surgery, lithium should be stopped. Lithium toxicity can be seen on different systems, on the CNS, on the cardiovascular, and also lithium levels increase if there is renal problems. So we need to take care that patient is not dehydrated. In case of diuretics and hyponatremia, the levels can rise. Post-operatively, after the patient is hemodynamically stable, only then the lithium can be restarted. Next group is our schizophrenia group, which is due to the dopamine level high activity in the brain, and the drug of choice in this group is the neuroleptic or the typical psychotics like haloperidol or our Serenase. The side effects of this high potency group is extrapyramidal side effects like dystonia, tremor, stiffness of muscles, speech, like something like the Parkinsonism disease. So nowadays we prefer atypical antipsychotics like clozapine and olanzapine, which do not have extrapyramidal side effects. Their action is very specific on the D2 receptors and also on the histamine and serotonin, as well as acetylcholine receptors. One side effect of clozapine is that it lowers the seizure activity, so patient can have epilepsy. Another side effect of clozapine is agranulocytosis. So, but like other antipsychotic drugs, they have to be continued till the perioperative period. So what are the problems that we face when the patient is on antipsychotic drugs in the post-operative period? These patients show more response to stress of surgery and anesthesia. They are confused when they come out of anesthesia. There is chances of water intoxication because there is hypersecretion of vasopressin. Chances of infections are more because the immune system dysregulation is there. One more thing about the neuroleptic malignant syndrome. It is a rare entity, but it is life-threatening disorder and it is secondary to antipsychotics. It is characterized by hyperthermia, muscle rigidity, and altered sensorium. There is increase in creatinine phosphokinase, and the treatment of choice is dantrolene. So one more precaution, our day-to-day drug, which use tramadol, should be avoided in patients on antipsychiatric because tramadol by itself causes dysphoria and hallucination, and it can precipitate the serotonin syndrome on patients. So another thing, before I end my session, I would like to say that we have to ask leading question about the antipsychotic drugs because the patients don't willingly give this history, neither do the relatives give this history. And I think one reason for that is the stigma, which is still attached to the term psychiatry. Thank you.
Thank you, Dr. Reshma, for comprehensively covering the topic.
Thank you.
I totally agree with the last point which you made, that we have to be very, very specific or means ask about the medicines, because usually they do not come out with this particular history. And then we can be in trouble or we can be for surprises. Related to the earlier talk, there was one question in the chat box related to this. Were there any complications related to your procedures which you have carried out?
Pentothal.
Pentothal.
Yeah, so in some patients, they went deep in when we gave pentothal. So we had to just make them awake, or in some patients, we have to put nasal oxygen for some time.
Right.
Other than that, we just stop when the patient stops talking or becomes slurred speech. So I stop giving the drug for some time.
Okay.
So it is not like our criminal that we have to hit the patient and ask. So we keep on talking the minute they start slurring speech. So we stop for 1 minute.
You have to stop. Okay. Was any patient admitted overnight because of being sedated or anything of that sort? Or all your cases you can...
So most of the patients were already admitted and they were already on some treatment. So when they come to the room, they are already little zonked. And so we don't need to give any midazolam or anything because their routine drugs are carried on till the morning at 6 o'clock or 5 o'clock. So we just give glycopyrrolate and pentothal.
Thank you. Shall we move on to the next topic?
Sir, can I just interrupt for a minute?
Yes, please.
Yeah, there was one question. Is the consent that you take for pentothal interview to be validated by law before going in for interview? Because it is a very privacy matter which are governed by fundamental rights. So Dr. Bhavesh Nanda has put up this question that should it be validated by law, the consent that we...
What does he mean by validated by law? If it is given by the person or his guardians in that particular case.
So there is no requirement for validation.
Informed consent. Consent. You need not go to the court. No? That is sufficient, I think.
Yeah. I think we can move ahead.
This privacy matter, the patient is subjecting himself to this particular test. He is coming to you voluntarily. You are not forcing it upon him, isn't it? Number one. And even for the criminals, consent is required. Even for the criminals, as per the law, latest means the mandate is consent is mandatory there. In case of patients come to us, come to the doctors. There is voluntary aspect is there. We are not forcing it upon them. That is one thing. But in case of criminals where it is used, the question of taking consent and validating, that will come into picture. In this case, it is accepted. Okay.
Hello, sir.
Haan, bola.
As we have some time, so Nilima will be speaking on substance abuse.
Yes, yes. Please go ahead.
So there's one more question, if I may take.
Yes.
What precautions we need to take in pregnant patient for LSCS in case of schizophrenia, and any medico-legal implications in absence of psychiatrist at center for the same patient? This is the question. Consent, precautions in LSCS for schizophrenia, and if psychiatrist is not present, then are there any medico-legal implications?
Medical means more than the psychiatrist, you have to be careful that the patient does not leave that hospital during her stay. Because per se, psychiatrist will not be required. Okay, if he is undertaking the treatment, you keep him in the loop. That is always better for the gynecologist. If he is knowing about the psychiatric treatment, if he is not aware about it, then it's slightly difficult. But the only problem which the hospital or the doctor may face is patient going away from the hospital, which has happened in Thane, that after the cesarean section, third day patient just went away. And you know, in our nursing homes, in all the nursing homes, you don't have that. This happened around 10-15 years ago. Closed circuit TV and all those things are not there. And usually we do not have a watchman in smaller nursing homes. So somehow she managed, and she was found dead on the tracks.
Oh.
Ultimately, since the family was known to that person, everybody, the in-laws and that lady's family, both the families, they were knowing about her illness, and the matter was sorted out. It was fortunate for the doctor and the hospital. Otherwise, this event may occur. The practical tip is, be sure that the patient leaves or a patient is taken care of in the hospital in a proper manner. But law will not say that you need a psychiatrist round the clock. It is always better you take the opinion for the good of the patient and like to save yourself also.
Thank you, sir. We can move ahead, I think.
Okay.
Good evening, everybody. Actually, as Dr. Bharave sir rightly pointed out, substance abuse is increasing among youngsters. And this is a very vast topic, so we cannot cover it in a short span. I will just touch upon some salient features. In substance abuse, there are a lot of drugs which are listed for substance abuse category, like cannabinoids, for example, weed, hashish, marijuana, charas, stimulants like cocaine or amphetamine, depressants like barbiturates, benzodiazepines, narcotics, hallucinogens, volatile solvents like varnish, etc. So I will not be going into detail of all this. I will just touch upon few points. Let us see about cocaine. So cocaine stimulates sympathoadrenal axis, causing hypertension, tachycardia, and ventricular arrhythmias. It can cause thrombocytopenia. So we have to be careful in preoperative period. You can see my slide?
Yes.
Yeah.
Yes.
So cocaine can cause thrombocytopenia. So we have to be careful during intraop and perioperative period. Cocaine decreases plasma cholinesterase levels, prolonging action of schooling. Then hypotension under spinal anesthesia can be ephedrine resistant. That we have to keep in mind. So drugs to be avoided in chronic users include ketamine, choline, halothane, selective beta blockers. Next is cannabis group, which includes weed, hashish, marijuana. Now these drugs also stimulate sympathetic nervous system, and chronic marijuana abuse leads to increased tar deposits in lungs. That we have to keep in mind, because this can alter the pulmonary function tests and also during intraoperative period, there can be bronchospasm. It also causes increased airway irritability. So we have to be careful about intraoperative bronchospasm. Now, anesthesia during acute exposure is dangerous and should be avoided. These drugs may enhance sedative hypnotic effects of anesthesia. Inhalational agents to be used with caution because they can lead to myocardial depression. Now, drugs like atropine and ketamine should be avoided in these patients. Hallucinogens like LSD, ecstasy. These drugs also stimulate sympathetic nervous system. Anesthesia during acute exposure is dangerous and should be avoided. They prolong ventilatory depressant effects of opioids. So we have to be careful about this, using opioids in these patients. Now, there can be exaggerated response for sympathomimetic drugs, intra. So while using these drugs for hypotension, we have to be careful. Then there can be prolongation of effect of scoline. Now, ecstasy users are prone to water intoxication and they can go into pulmonary edema. So fluids should be tailored. So basically, when there is a possibility that a person can be substance abuser, we have to inquire, and if history is not possible, then at least we have to keep in mind while using certain drugs like scoline or sympathomimetics or halothane or beta blockers, whatever drugs, we have to be little careful and we have to tailor-made the use of these drugs. And basically in acute phase, intoxicated phase, obviously it is dangerous, and try to avoid elective cases. But in emergency situation, if we have to give anesthesia to these patients, it is better to give regional anesthesia than general anesthesia. And because regional, as I told you, general anesthesia, there are a lot of anesthesia implications and drug interactions because of these drugs. So thank you very much. And actually, this is in very short. This is a very vast topic which we cannot cover in such a short span of time. Thank you so much. Over to you, Dr. Barve.
Thank you, Nilima. Thank you, Nilima. What is necessary is high index of suspicion. We have to be careful when we feel that a particular case may be a victim of drug abuse who has landed to you for any surgical procedure. So high index of suspicion will be very important in all these cases. As you rightly pointed out, although this regional anesthesia is good, but excess means hypotension may be severe in these cases in certain with certain drugs, and problem of bronchospasm and certain other complications when we give general anesthesia. Thank you very much again. Now, shall we move to the next topic, please?
Yes, sir.
Now, one more anesthetic agent, that is ketamine, also finds a place in providing some help in managing some psychiatric cases. Now, I call upon our friend Dr. Tushar Dedia to enlighten us on the novel use of ketamine. Dr. Tushar Dedia is a practicing anesthetist. He did his undergraduate from Sion and postgraduate from Nair Hospital. He is in private practice for more than 30 years. Over to Dr. Tushar Dedia.
Thank you, everybody, for allowing me opportunity to speak. My topic is recently new, but everybody must be aware of this ketamine. Some people are not at all aware about it. Many anesthetists whom I spoke recently, they say, ketamine for anesthesia, for psychiatric depression. I don't know at all. But let us enlighten our such friends about this. About my outline, I'm going to speak first on general introduction, efficacy, adverse effects, indication, dose, and notes, parting notes. Ketamine was first studied for psychiatry in Andrade 2017. Introduced as an anesthetic drug in 1970, dosing for anesthesia 2 to 3 milligram per kilogram, has demonstrated efficacy in adult and pediatric practice. In sub-anesthetic doses, it has many off-label indications. At least 10 to 20% of patients suffering from depression meet criteria for treatment-resistant depression. Ketamine off-label indications are many, like pain management in emergency room, cancer, pain, refractory headache, then agitation, violence, the analgesia, then body drug or army feed, sedation, then recent addition to the list is depression. The initial studies were done by Mr. et al. In 1994 on 19 normal volunteers in the dose of 0.1 to 0.5 milligram per kilogram body weight across 40 minutes IV. Study of psychotomimetic and other effects were done. This had the default parameter for future study. Herman et al. Studied at the dose of 0.5 milligram per kilogram body weight IV across 40 patients in monopolar depression. Antidepressant effect was evident at 4 hours and persisted for 3 days. The another study was done by Zarate et al. 0.5 milligram per kilogram body weight IV across 40 minutes. At 1 day, response rate was 71% and remission rate was 29%. Response attenuated but still evident at 1 week. Meta-analysis was done by Kishimoto et al. Ketamine versus control antidepressant benefit event evident at 40 minutes. It reached high 1 day and lost in 10 to 12 days. Almost all the data was from monopolar depression patients. A few studies included bipolar patients. Benefit loss earlier is 3 to 5 days. In suicidal patients, single and repeated dosing of IV ketamine was studied. Attenuation of measure of suicidality in treatment-resistant depression was achieved. Benefits tend to wear off within a week's time. Anti-suicidal effect is hardly independent of the antidepressant effect. Monotherapy versus augmentation. Escitalopram in severe monopolar depression was also given single dose of IV ketamine at the start of the management. Response rate was 92% versus 57%. Remission rate was 77% versus 14%. Response and remission occurred earlier with ketamine. About adverse effects, all causes of discontinuation, no difference between ketamine and control. Dissociative and psychotomimetic effects were more common with ketamine, but they were very short-lasting, usually for 2 hours, 1.5 to 2 hours maximum. Commonest adverse effects were seen within first 4 hours. Drowsiness, dizziness, poor coordination, blurred vision, feeling of strangeness or unreality. Adverse effect goes off in subsequent hours. Usually, these adverse effects are not of very much clinical significance. During ketamine IV sessions, blood levels are well below those associated with ketamine anesthesia and below the levels associated with awakening from anesthesia. Patients are almost always awake all throughout the ketamine session. Oxygen saturation is also within normal limits. Respiration is also normal. One case of manic switch was reported in Indian Journal of Pharmacology. Mania may be prevented by including antipsychotic or mood stabilizer co-medication. Long-term high-dose abuse has been associated with medical risks such as cystitis. No long-term consequences have been identified with low-dose intermediate controlled medical use. Ketamine rated as a generally very acceptable management. Adverse effect may decrease during maintenance therapy. reducing ketamine adverse effects, pre-treatment with oral clonidine to reduce heart rate or blood pressure. Intranasal dosing may have fewer adverse effects. Lower doses have fewer adverse effects, but may have less efficacy too. Glutaminergic drugs such as lamotrigine may reduce adverse effects. How many sessions are needed? If there is no response, increase the dose from 0.5 to 0.75 milligram per kilogram body weight or continue sessions. Declare futility if there is no response after 6 sessions. Indication of ketamine is mainly monopolar depression, possibly in some case of bipolar depression as well. Context of ketamine are severe illness, suicidal risk, social need for rapid response, treatment, refractoriness, acceleration, improvement of responsive to antidepressant ECT. Indications are the most studies are done with monopolar depression patients. Few studies included patients with bipolar depression. It is possible that benefits are lost earlier in patients with bipolar depression. In suicidal risk, efficacy is there when patient cannot be admitted or otherwise supervised, contributes to crisis intervention, help until other adverse interventions are instituted and take effect. Benefits of giving in patients, suicidal risk patient, wear off in 7 to 10 days, but this time of 7 to 10 days can allow us to initiation of other intervention. Ketamine may become an important to manage suicidal depression in clinical practice. No advantage of ketamine in comparison with ECT. No advantage for ketamine at the end of ECT management. Ketamine use associated with acceleration of early response at 1 to 2 and 3 to 4 weeks. Both meta-analysis shows increased adverse effect risk, especially after post-ictal agitation, confusion. It may be hard to improve the outcome with ECT, which is the standard mode of management. Dosing, the standard dose is 0.5 milligram per kg body weight, regardless of routes used. As ketamine studies have been administered in half the doses, but doses of 28 to 84 milligram up to 6 weeks has been administration. Very small crossover RCT suggests that doses as low as 0.1 to 0.4 milligram per kilogram body weight may also be therapeutic in some patients. Rate of administration, it has been given as intravenous infusion from 2 to 5 minutes to 100 minutes. Implications of convenience versus safety: 100 minutes to obviate the need for anesthesiologist supervision, 4-day continuous infusion to break the depression outcome, no different from that with single 40-minute infusion. Rate of administration with intranasal route from 2 minutes to 30 to 40 minutes, then oral route as a bolus, intramuscular subcutaneous has also been used, but no apparent difference in efficacy. After effects, the adverse effects may peak with bolus dose regardless of use routes, but no head-to-head trials have been done. There are 8 routes of administration have been studied by Andrade. Then one is oral, sublingual, intramucosal, intranasal, the nebulization, intravenous, intramuscular, and subcutaneous. Intravenous is the best route which has been investigated. Intravenous has most impressive results. Important for non-spective factor in psychopharmacology, plasma levels with IV are double than those of intramuscular or subcutaneous dose. Now, about oral administration may be easiest, especially for repeated doses. Compensate the dose by increasing the dose because of the less absorption. No different from many oral psychotropic drugs can be used for domiciliary management as in cancer, pain, or depression, but there is a risk of misuse abuse in psychiatric patient needs to be formally studied in clinical trials. Subcutaneous administration may be preferred for clinic-based management, more convenient among parental route, especially for repeated dosing. Large number of sites are available. Rotate the sites need to be formally studied. Frequency of administration. Best to administer the next session a little before the benefits of previous session wear off. It is done by trial and error method. In studies, continuous treatment has been examined for up to 6 weeks. Maintenance treatment has been described for up to 5 years. Some studies, especially initial ones, studied ketamine monotherapy. Many subsequent studies use ketamine in addition to ongoing management. As with ECT, it may be best to continue antidepressant drug during ketamine treatment also. For drug interaction, pharmacodynamic interactions are predicted by its pharmacological effects. Drugs that block NMDA may reduce ketamine adverse effects. Benzodiazepine may reduce the efficacy of ketamine. It is metabolized by various enzymes like CYP2B6, etc. Drugs that inhibit or induce these enzymes substantially affect ketamine levels. Inducers like rifampicin, St. John's wort, and inhibitors like itraconazole, macrolides, grapefruit juice, etc. They inhibit the effect of ketamine. Mechanism of action. Ketamine blocks the NMDA receptors. This mediates its psychotropic and dissociative effects. This may not mediate its antidepressant effect, what mediates its antidepressant effect is still unknown. Perhaps it blocks the GABA receptor interneurons that inhibit glutaminergic neurons. That this releases the glutamate stimulating AMPA receptors. There is downstream facilitation of neuroplasticity. IV ketamine sessions are best conducted in minor OT and be done on OPD basis. Dilute ketamine in 100 ml or normal saline at the dose of 0.5 milligram per kilogram body weight. Slowly IV to be given over a period of 30 to 40 minutes. Monitor pulse, BP, oxygen saturation before, during, and for 2 hours after the session. Cautionary note: ketamine does not have a label for use in depression, but research on intranasal delivery of ketamine may result in a label. Use this ketamine with extreme descent. Less is used may be prohibited. Limitations: the long-term efficacy of ketamine has not been investigated by most studies. The psychotomimetic properties may complicate the application of this pharmacological agent. In conclusion, ketamine may be considered as valid and intriguing antidepressant option for the treatment of treatment-resistant depression. Further studies are needed to evaluate its long-term antidepressant effect in therapy with patients. Thank you very much. Over to you, Mahesh.
Yes, thank you, Dr. Tushar. It is heartening to note that one more of our anesthetic agent is of some help in treating cases of depression. Now, I would like to ask you some questions. Are you following this particular this treatment or helping somebody in this treatment?
I'm helping somebody in treatment. Initially, I allowed my psychiatric friend to do along with me. I informed him how to do it. At present, since last 1.5 years, he is doing it alone. Okay. No help.
No help.
He is doing alone.
Yeah.
On OPD basis.
मोबाईल वरती आपण अभ्यास जो करतो त्याच्याने पण त्या मोबाईल लाईट मुळे आपल्या आयरिसला जे पेनिट्रेशन होतं.
Hello.
Yes.
At present, I am working with one of my psychiatric friends. Initially, I used to do work with him, and then I instructed him how to do it. And then at present, he's doing alone on OPD basis regularly, without anesthetics in the hospital setting.
Secondly, these oral preparations, are they available in India right now? Are you aware about that?
As ketamine is not available, oral preparation also not available. I think liquid ketamine was available earlier sometime, but nowadays I think it is not available. Ketamine syrup, if I am not mistaken.
Is anybody else aware about the availability of these agents in this particular form? I would put it to the audience.
Nobody, I think, is aware.
No,
India, I think
India, it is not available right now. Right.
India is not available. As ketamine also is not available.
Okay.
And sorry for my interruption in speech problem.
No problem. Thanks a lot, Tushar. Again, any more questions for Tushar?
Yeah. For the lady patient, hello.
Can I ask one question?
Yes, sir.
Yes, sir.
Have you seen any delusions and hallucinations with these using only ketamine after the use of ketamine therapy?
No, sir. No. Not a single patient.
Because that's one of the major complications of using ketamine, the delusions and hallucinations, unless you give some other medication. So how is it that you did not see any in any patient? What is the explanation?
No, sir, not a single patient. Not a single patient.
What is the explanation I'm asking?
No, because we give it in sub-anesthetic dose. Anesthetic dose is 1.5 to 2 milligrams.
But you said you are going almost up to 0.5 milligram per kilogram also, no?
0.5 is the minimum.
You went beyond. No, minimum. So actually, 1 milligram per kilogram makes it about 50 milligrams of ketamine in a patient. So 50 milligrams can also cause enough delusions and hallucinations. I've seen many.
Yes.
0.5 milligram per kg. Just half a cc.
Half a cc is also, that also can cause some
That too in 100 ml of NS over a period of half an hour to 40 minutes. In anesthesia, we give just like that immediately, slowly over a period of half minute to 1 minute. But here we are giving over a period of half an hour to 40 minutes. So that
I agree. I'm not denying your observations, but what is the explanation I'm asking you? Why?
Explanation I am not aware of, sir.
Yeah, the dose may not be sufficient to cause that.
I don't think so. It's enough dose he is giving is 0.5 milligram per kilogram is quite a lot.
So
If you
over
have a
45
60.
So it's given over 45 minutes and patient is usually on some other drugs also.
That's what I'm saying. Unless there are some other drugs given, then only you can have it. Not only modified. You have to modify it, then only it can be caused. Yeah.
This is additional treatment being given to him.
Fair enough. Fair enough.
It is not the
And
only
Dr. Jolly, for you.
additional to other psychiatric drugs.
Yes, sir.
Okay. I want to ask you what are the total incremental dose and what is the post therapy? How long do you ask the patient to wait?
So most of the time the patient is already admitted in this hospital. But if it is an OPD patient, we make them wait for 4-5 hours or at least till they are able to go to the washroom.
Right. I think that is that caution you should tell all the youngsters in particular, not to allow the patient to go away immediately within 1 hour, and otherwise you'll be called for some complications. I just want to warn the other youngsters particularly. Thank you.
Thank you, sir.
Thank you, sir. Thank you very much.
You want to ask something, no?
डॉक्टर गुड बोले
बंद करा
No. With ketamine, there was allegation that some female patients had alleged long back after use of ketamine about sexual harassment and all that. So could this be a problem with female patients?
No, sir. The patients are almost always aware, almost always awake, like us, all throughout the session. Patients are 100% aware, and some we make some ability of the patient to be with the patient. Patients are not given ketamine alone.
Alone, yeah.
We
The
must
attendant is
take
there
some
in the
ability to spend with time with the patient.
Why not to use oral for long-term depression?
Not available, sir.
Availability nahi.
Availability problem.
The taste is bitter. Whatever right now we are having is bitter, bitter to taste.
Bitter taste cannot be palatable.
Not palatable, right?
Put in the juice.
So one question about psychiatrist. I know the dose is less and it is given over a long period of time, but is a psychiatrist actually allowed to give ketamine?
No.
Yes, yes.
No.
I think they're allowed. So they're allowed.
They're allowed?
They're allowed, officially allowed, but there is no label for antidepressant use on ketamine. It is not officially, it is internationally recognized about antidepressant effect, but psychiatry, it is not labeled as antipsychotic drug.
Okay.
So I don't know about this question whether they're
technically they are not allowed. Means it is not safe.
They're allowed.
Inside, I always go for all the therapies. I sit there for 45 minutes and they never give it without anesthetist.
That will be better.
Yeah. They have 6 cycles alternate day, but every time the anesthetist is sitting there.
Okay, we do it alone. My psychiatrist does it alone.
In California, can I talk?
Yeah.
It is officially allowed in California, and most of these clinics are known as the ketamine clinics. And these ketamine clinics are run by the anesthesiologists.
Okay.
So, and these clinics are very popular. Actually, once I happened to go to the clinic, but I could not dare enter in, since I got scared that there may be some hidden video cameras and all this. But this is very popular, and these clinics are doing great business also. And it is an official part of a treatment for the patients who are suffering from chronic pain and patients who have got psychiatric problems. And it is officially allowed in California, not that something illegal. So I think it will be a new avenue for the anesthesiologist.
Yeah, it is a new avenue.
Yeah.
Thank you, sir.
Okay. Any more questions? No. Dr. Barve sir, do you have any to make?
No. Thank you.
Katkade sir.
Hello.
You said that ketamine clinics are there, but then who decides to give ketamine?
Anesthesiologist.
Psychiatrist or anesthetist?
Anesthetist. Patient go of their own.
So patient decides that I want a.
Yeah, this patient decide. I mean, I don't have the experience, but I saw the board. It's so impressive. And if you go.
No, sir, but are these clinics for depression or are they for?
That is what.
They are called regular ketamine clinics.
Euphoria.
Because ketamine is a very well-known party drug and people are using it left, right, and center. So, like, just for euphoria, like somebody said, yeah.
But I don't know, you have to be very careful, because you don't know the legal aspect of it. Once in a while, patients could not come and say that the particular doctor made me addict to the ketamine and all this, You have to be very careful.
Ideally, the treatment should be prescribed by a psychiatrist, and if you are going to do it in conjunction, that is the safest way and the legal way to do it, actually. Like psychiatrist advising in presence of anesthetist, the thing is carried out, and that's the end of it.
Okay, sir, anything else or should we conclude?
Yes, you can conclude.
So again, vote of thanks from my side. First of all, I want to thank all of you for being present here. We had a good attendance of almost 70 to 80 people, which is very heartening. This topic was very offbeat and something that we have not discussed any time before. So I want to thank my clinical secretary, Dr. Nilima, for coming up with this brilliant idea of having a session on anesthesia and psychiatry drugs. Special thanks to Anjali Deshpande for taking a busy schedule But sir,
Manisha,
sorry. Sir, you will have to unmute yourself if you want to say.
yeah, I just want to say that I must compliment the entire team for thinking of a totally offbeat topic. It will definitely stimulate people to think of these lines. So congratulations for the whole team. All the best.
You, sir.
Thank you so much.
Yeah. So that was a very nice session.
Manisha, you are muted now.
Sorry.
Manisha.
Yeah. So thank you, Nilima, for this excellent idea, and thank you to Dr. Anjali Deshpande for taking time out and giving us some really good tips. I think all of us should now aim for that BMW and not be happy with just our Mercedes or Audis. And of course, sleep, exercise, and eating, we already know are the mantras of a happy life, and these we should be trying to follow. And, thank you to Reshma and Dr. Tushar Dedia for volunteering and agreeing to our request to speak on this topic immediately. And Dr. Barve sir, as usual, it was excellent listening to you and your comments, and the way you summarized everything was really very nice. We will come up with more innovative sessions as it progresses. And if anybody has any ideas, please put them forth. And if anybody here wishes to speak on any topic with us, we are always on the lookout for new speakers and want to. So thank you very much, and I wish you all a very good evening and good night.
Good night.
Thank you. It was wonderful. Wonderful session. Yes.
Special thanks to Tushar and Reshma.
Yes.
Chalo, thanks. Congratulations. Thank you very much.
Thank you, sir. Thank you.
Chalo.
Thank you.
Nilima,
Bye. Good night. Good night.
Good night. Bye.
Nilima,
Good night.
you are doing excellent job. Really, very nice.
With support of everybody.
No, but still means really good.
Lovely.
Bye. Thank you, everybody. Good night.
Yeah.
I didn't care, then I got scared.
They say oral ketamine is not available, but I learned from the newspapers that boyfriends are putting ketamine in girlfriends' drinks.
Yes. Actually, you know what? This ketamine, you see what has happened. Ketamine lollipops, I had read about ketamine lollipops. And once a while, when this is just off the record, once a while I happened to talk to a drug inspector when I went for a fentanyl license. I said, why are you putting so many rules and regulations, particularly for the anesthesiologist? You know, patients in duplicate, keeping a prescription. He said, doctors, we don't know. There are lots of things, this ketamine and other things. We raided one chemist who has a great turnover of a ketamine sale. And it was shocking to see that this ketamine was sold in North India. This ketamine was sold in North India, and you must have heard that one passenger giving biscuits to other passengers on the way, and then the next passenger, the person who enjoys the biscuits, he gets looted. So ketamine is the commonest drug that has been used for this.
Previously, Serenase was used. Serenase.
Yeah, but you don't know once. I think, and like this, we know this Michael Jackson. He had employed a doctor in his bedroom. So this particular society, but this drug, I mean, anesthesiologist, it's a great thing because chronic cancer and as anti-psychiatric, antidepressant, it will be a great use. And I think somewhere I read vaguely in enhanced recovery after surgery, patients who received a ketamine, I may be wrong, I don't know. And then the propofol, ketamine is the analgesics, and this has got a good analgesic property of post-operative. And these patients, they do enhanced recovery of surgery. It was well mentioned that patients who were given ketamine subclinically also did very well in long term. But which I don't know, I don't have a reference, but somewhere I read that. I think all these drugs are great future.
Yes.
Good, very nice. Thank you very much. Congratulations. I said, congratulations to the whole team. Yeah, it's a great thing. So, bye-bye.
Bye.
Bye, sir. Thank you.
Bye.
You will get the interest.
Bye.
Bye. Bye. It was so nice to see everybody again. Yeah, lovely. You're looking beautiful, Meenal, with this pearl.
Oh.
Yeah, it's looking very good. Hi, Manisha. Hello, sir. Hello, sir. Nine is saying hello to you.
19 to 20, 21, 23, 24.
Hi, good evening.
Hi.
So nice to see all of you.
Yes.
God bless, sir. Yeah, bye.
Bye. All the best. Thank you.
Thank you, Katkade sir.
Yeah, thank you. I think Minal,
Oh, yes, sir.
you have better necklace. You must have President's gold medal there with you, no?
Oh, God.
So next time whenever you sit for a meeting, you must wear that President. So I suggest,
Okay.
it's worth wearing this. But it will look lovely. Parna ka baro dhyan gaya necklace.
सर हमारा ध्यान इसमें ही रहता है नेकलेस है वो
तो लेक्चर सुनती है क्या नेकलेस पहना क्या पहना वो देखते हैं
सब कुछ The first session was excellent. Very good. It was.
Very good. Chalo, okay, bye.
Bye.
See you.
Hello, Nivedita ma'am. Can I end the meet?